This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm your host, Vahid Sadarzadeh, and today, I wish I had the jingle on me, because have you heard the TikTok jingle?
No, what's the jingle?
Ozempic.
Oh, yeah.
It works, or whatever the jingle is. So today, we are talking all about Ozempic, and not necessarily in this podcast all the side effects or pluses or minuses of it, especially for those people who are working out or any other scenario, but surgery. So we're going to talk about how it relates to anesthesia. I think this came up, Brian, a few weeks ago when a former colleague of mine said that her mom was going in for surgery, and they kind of canceled the surgery last minute because she's taken the Ozempic shots. So let's talk about it. And it's not just Ozempic, it's Wegovy.
Yeah, there's a whole big list of them. So probably before we get started, we should talk a little bit about what these drugs are. So they're called GLP-1 agonists. It's a long word, glucagon-like peptide 1. So the way these medications work, and they've been around for quite some time for diabetes, the basic gist of how they work for diabetes is that they sort of regulate the insulin and glucose levels in the body. So they help to drop the glucose and improve your blood sugars. What they found out, though, when people that have diabetes are using these drugs, they ended up losing weight, a significant amount of weight. And so the initial study said anywhere from 5 to 15% of their body weight when they started the GLP-1 agonist. So they did a little study on that, and basically the way that the medications work for weight loss is that aside from just the regulating insulin and glucose, which is helpful for weight loss as well, probably the main thing that they do is they reduce gastric emptying. So basically what that means is when you eat something, it sits in your stomach a lot longer. When it sits in your stomach, both mechanically and hormonally, it makes you feel more full. And so if you're more full, you're going to eat less. If you eat less, you're going to lose weight. I was doing a little bit of reading here a couple of weeks ago on them as well. And so there's a few other things that these GLP-1 agonists actually do. They go to the brain, a couple of places in the brain, the hypothalamus, as well as the limbic center. So these are parts of the brain. The hypothalamus controls metabolism and all that sort of stuff, and the limbic system controls reward and pleasure seeking. And so by going to the hypothalamus, they actually reduce your hunger drive, and they change the way that you crave. And this is it was only one study, but they change the way that you crave certain things. So as human beings, we crave things that are calorie dense, right? So fatty foods, sugary foods. By using these medications, the receptors in the hypothalamus decrease your desire for those and increase your desire for supposedly more healthy things. And then there's GLP-1 receptors in the limbic system as well, which is the system of your brain that controls reward. And so there's some theory out there that they also reduce the amount of reward that you get from eating foods. And so usually that's like sugar, right? People talk about sugar as just as addictive as cocaine and that sort of stuff. So the medicines work a whole bunch of different ways. Probably the main mechanism, though, is slowing down the emptying from your stomach into your intestines. And so this is where the anesthesia issues come in, right? So
time out before we get to the main topic at hand here, or like the surgery part of it. What are the differences between Ozempic, Wegovy, and there's another one, right, that's on the market right now, or are those two the main ones?
Yeah, so the tirzepatide. Sorry.
No worries. You need some liquid death over here.
That's the problem. Wrong pipe.
So I think the question was the main differences between Wegovy and Ozempic, and is there another one that's on the market?
So there's a bunch of them out there, and so we really split them into the injectables and the oral medications. So Ozempic, Wegovy, and tirzepatide, which I can't remember the brand name for that. These are all the injectables. So you inject them once a week. It's a depot formulation, means it sits there underneath the skin and the subcutaneous tissue, releases slowly over time. And so Ozempic and Wegovy are very similar medications. They're both semaglutide, which is the generic name for the drug, the GLP-1 agonist. So you've got Wegovy, Ozempic, tirzepatide, Those are the weekly injectables. There's also daily injectables. Those aren't really used for weight loss. These are more the medications that are used for diabetes only. The issue there is that they're just not as good at the gut system as the other ones. Then you've got the oral medications, also semaglutide, same medication, but an oral formulation called Rybelsus. That's a daily pill. In general, people are taking, and there's actually a third. Yeah, you're right. The third one's Mounjaro. That's also Mounjaro. Yeah, that's also semaglutide. So this is like the difference between Pepsi, Coke, and Tab, right? It's all the same stuff. It's just branded differently, and the formulation's a little different. So it all works essentially the same way. So the injectables, especially the Ozempic, Wegovy, Mounjaro, the ones for weight loss, you do once a week. Okay. The only oral one that I know that's on the market, aside from the generic semaglutide, is Rybelsus. That one's daily, and that one's for weight loss as well. So in general, those medications are injected once a week. Start at a low dose and then kind of go up. I can't remember all the dosing. I think Ozempic goes like...
So once a week?
Yeah, once a week. It's like 0.6, 1.2, 2.4, something like that milligrams. And so it lasts that whole week. And so...
and that works, again... It controls how much food gets released to your
correct, yeah,
and then it also works emotionally to.
There's some theory that it also goes to the brain and works emotionally. So in general, it's all the things that it does are making you less hungry and desire food less. So I mean, it's a great side effect that they found from these medications they use for diabetes. On top of that, one of the biggest predictors of longevity in general is blood glucose levels, keeping your blood glucose levels below 100 at all times, essentially. So the medications work as well long term to increase longevity. The other thing is they just got an indication for prevention of cardiac disease, congestive heart failure, all that sort of stuff. So even if you're not diabetic, technically, if you have any glucose abnormal glucose levels at all, even if it's not fully blown diabetic, then these medications are indicated to prevent coronary disease. So, I mean, they're going to have a ton of indications.
All right. So I'm going to ask an obvious question here. If it's so good for you and you lose weight, why is not 95% of the general public just going around and taking this medication of weight loss and diabetes prevention and heart? Like what is, I mean, there has to be some negative to taking this drug.
So the primary negative is cost. None of these medications are generic anymore, or are yet. I'm sorry, none of these medications are generic yet, which means they're all brand name, which means they cost a lot of money. Even if you're diabetic, I hear people say these cost $300-400 a month, So
really?
Yeah. So this is an interesting stat. Novo Nordisk, which is the company that makes Ozempic, they're based in, I think, Sweden. It was either 2022 or 2023. Their profit was more than the rest of the gross domestic product of the entire country of Sweden combined.
What?
Almost completely based on Ozempic. They make a bunch of other medications too, but Ozempic is by far their biggest seller. By far.
How come? I mean, it's been used for a while. How come now? Like, is it just in the United States that it's catching on?
No, it's everywhere. It's all over. It's
everywhere.
All over the world. Again, it was used primarily for diabetes. Once you get an indication for a certain ailment, so let's say diabetes,
sure,
you have to study it for a while after you release it to figure out what it's doing, positives, negatives. And so it took them a while to figure out that it was causing a bunch of weight loss. And then once that happened, people started using it off-label for weight loss. And now the medications have been indicated and then some created, like Mounjaro and Wegovy, for weight loss exclusively or primarily. So, I mean, it just takes time for this to happen. I can't remember how long ago Ozempic came on the market. It's got to be 10 years at least. But
it's crazy because I've only heard of it like the last couple, even year or so.
Well, you hear about it for weight loss, right? Right. You never hear about the diabetes medications, right? Yeah. Have you heard of Victoza, Jardiance? Like aside from commercials,
except for commercials. Yeah, right.
Nobody cares about these medications unless you're on them.
Right.
It's this whole big weight loss craze. And so I think one of the first people who came out and talked about it was Elon Musk.
Okay.
Talked about how he used Ozempic. Yeah. So I mean, I think that they're very powerful medications. So cost being the number one negative. There are a few things. So particularly the injectable medications. So bleeding. We hear a lot of people talk about nosebleeds.
Yeah,
that's probably one of the biggest things. You get all the GI symptoms, right? So anything that makes your gut slow down is going to give you some nausea, some dyspepsia, some issues with diarrhea and just bloating and that sort of stuff. So, I mean, those aren't terrible side effects, but I'm sure they're not comfortable. So people aren't, incredibly excited with those side effects. For patients who are diabetic, there is some increased risk of retinal issues, diabetic retinopathy. I don't know where that comes from or why, but and then anytime you inject yourself, you got a risk of bleeding and infection. So there's all that. The oral medications.
That's in the buttocks, right?
It just depends. Usually people do it in their belly. Yeah.
Gotcha.
You can do it anywhere where you've got fat. Basically, you want to absorb into the fat in the subcutaneous tissue. The Rybelsus, the oral medications, seem to have less of these side effects. They also don't work quite as well as the injectables. So, your weight loss is probably more with the injectables. The overall just ability of them to treat blood sugars and all that sort of stuff is probably a little bit better with the injectables than the orals. So should we get into why do we care in anesthesia? Yeah.
Yes, absolutely.
Just as a summary, overall, these drugs are really, really good for weight loss. 5 to 15% of weight loss, 5 to 15% of your total body weight. Often people lose relatively quickly. And the other thing we didn't talk about is coming off the medications. So initially, when they were taking people off these medications, they were just pulling them right off, just taking them right off the medications. Cold turkey.
You're a doctor and you're like, stop taking it.
Yeah, you've lost 50 pounds, stop taking it. What they found is there's some rebound with that.
Sure.
So they're slowly weaning people off the medication. Seems to help quite a bit. And the other side effect that we didn't really talk about, because it's fairly rare, two things. One, it can cause a little bit of kidney damage, pretty rare, especially at the doses that we give patients these medications.
This is both the oral and the injectable.
Yeah, all of it can cause a little kidney damage. And then they warn patients who have a history of it's MEN2. So it's basically a thyroid type disorder. And so apparently this can increase the multinodular. Anyway, it can increase your risk of that cancer coming up or recurring or something like that. So that was all done in rodent studies. I don't know if it's, I mean, I haven't heard personally of any evidence that this actually happens in humans, but they warn you anyway. Multiple endocrine neoplasia type 1. That's what it is. There we go.
I'm going to remember that.
Going all the way back to medical school for that. So anyway, they just warn you about thyroid stuff.
Gotcha.
So, okay.
As it relates to surgery.
Yeah, transitioning into why do we care in anesthesia. So, as we've talked about over and over again, don't eat before surgery. We're worried about you throwing up. If you throw up and it goes in your lungs, that's called aspiration. So, aspiration's a big, big deal, 50% or more fatality rate.
Yep.
So, if you've got a medication that slows down gastric emptying, you've got more food in your stomach, higher risk of aspiration. So, the ASA, our governing body in anesthesia, look through some of the studies and then actually did some observational studies themselves, and they were finding undigested food in people's stomachs, even who had been NPO or hadn't eaten anything in the correct amount of time, 8, 12, even 16, 24 hours. So I think it was in 2022, the ASA came up with a recommendation that that patients taking the injectable forms should hold off for at least 1 full week, so 7 full days. With the injectables, which just basically means if you're going to have surgery on Monday, you shouldn't do your injection the Monday before.
Is this like you have to, or is this like doctor recommendation?
No. This is you have to. So
gotcha.
So what we will cancel surgery if you don't do this because your risk of aspiration goes up. I think their one observational study said the risk was up like 30 or 40%. So an elective procedure, we just don't do it because it's not worth it, right? It's the same thing as if you would show up and have eaten breakfast.
But if it's an emergency...
we have ways that we can sort of prevent aspirations called rapid sequence induction. We talked about this a little bit for trauma. But again, there's still a risk. Even with a rapid sequence induction, you still got a risk of aspiration. So we're just not going to do it for an elective surgery.
Right.
So the current guidelines are at least 7 days. So skipping that dose within a week of surgery for the injectables, and for the orals, a full 24 hours. So for instance, if you take it in the morning and your surgery is the next morning, you skip that dose that day. Sometimes we say the day before, depending, if you've got a surgery that starts at 6:30 in the morning and you typically take it at 9, we're going to say skip your dose the day before. Now, they're still finding, even with these recommendations, patients with undigested food in their stomachs being appropriately NPO. So the rumor, and it's not official, but the rumor is they're going to change it to 2 full weeks off of the injectables and at least 48 full hours off of the oral medications.
And that's what I believe they did for this friend of mine, her mother. I think they waited 2 full weeks because of the injectables.
Yeah, and some anesthesiologists are just pushing it that way because they're seeing so much of this. Add to that patients who are obese and diabetic already have gastric emptying delay. That's just part of it. Gastroparesis is just part of being obese, and part of having diabetes. So you add all these things together, and there's just not food getting through the stomach.
2 full weeks
For the injectables, yeah.
But like,
No. It's not the food goes in 2 full weeks. The food was, you ate the food, let's say 12 hours ago. Your 2 full weeks to allow that to get out of your system.
right.
So that it's not causing the gastric emptying.
What is the
delay.
normal time? Let's say you're not on Ozempic.
Yeah.
For an average 40-year-old male or female, what is the average time that food should get digested through the system?
But so it depends what you eat, right? That's what our NPO guidelines are based off of. So clear liquids, if I'm drinking, I'm drinking Liquid Death, right? Liquid Death is a clear liquid, although it's got a little sugar in it, so maybe it's not totally clear. But anyway, that we've got a clear liquid here, right?
Sure.
Supposedly within 2 hours in basically all patients, that's through the stomach, right? So we say if you have water before you come to surgery, if your surgery is at 9 a.m. and you drank water at 6:30, you're fine, good to go. Then you've got the next step is breast milk, which why is it different? Who knows? But breast milk is 4 hours.
Sure.
Okay. So if a baby is breastfeeding, you say, okay, your surgery is at 10 a.m. Stop breastfeeding before 6. Fine. I mean, that doesn't really. I don't do a whole lot of really small babies, so that doesn't really affect us. For other foods, whatever the case may be,
Chicken breast, steak.
breakfast, lunch, dinner, whatever. The studies were based on, I believe it was 2 over easy eggs and a piece of toast. And so they did these studies back years and years ago. They showed that in a otherwise healthy, I can't remember, I think it was medical students, so in their 20s, was through the digestive system, through the stomach within about 3.5 hours. So,
Okay.
And if you take the full distribution, right, slowest to fastest,
Sure.
you're probably about 4.5 to 5 hours. So they made the guideline 6.
Okay.
For a small meal. That's what the guidelines say. A small meal in an otherwise healthy patient, 6 hours. It's probably out of your system in 4, but by a couple extra hours. So let's say you're having surgery at 10 a.m. You can't eat anything after 4 a.m. And that's usually why we say don't eat after midnight, because most people aren't going to wake up, 3:30 in the morning.
Right.
Right. So
a week to 2 weeks, that's for
well, so you're only stopping the medications a week to 2 weeks. I'm not telling you not to eat for a week to 2 weeks.
No, but like that's the amount of time if they're seeing it, right, still a week out. That food has been in your system for a week?
No. So
I'm misunderstanding that.
Yeah. So we're telling you to stop taking the medications for a couple weeks so the medications aren't slowing down your gastric emptying.
Got it.
NPO guidelines don't change, right? So you still have to be 8 hours. Again, we usually say after midnight, but you still have to be 8 hours without eating. It's just that when you take those medications, they're finding undigested food after that 8 hours.
Got it. So after that 8 hours,
right.
That's where I was disconnecting.
Yes.
But how long does it take, though?
They don't know.
Like, if I'm taking the Ozempic, if I'm eating the same 2 eggs and a piece of toast...
They don't know yet. Nobody's done the studies.
Wow.
So, I mean, again, you're finding it in... So I think the case reports have had people stopping at dinner time, so let's say 6 p.m.
Sure.
And then having surgery the next morning. So you're probably 12 plus hours, and there's still completely undigested food there. So that's at least 3 times longer.
Right.
The reason for waiting a week initially is that the half-life of these medications is, I think, like 16 hours or 20 hours, something like that. So basically the way that it works is by 5 half-lives, the medication should be out of your system.
Gotcha.
Right? So if a half-life of a medication is an hour, within 5 hours, all the medication should be gone. It shouldn't have any effects anymore. Or basically all the medication. So if it's, let's say 20 hours,
sure,
then within 100 hours, all the medication should be gone and not working. But there's probably something else going on. It's not just that the medication is still in your system and still working. It's probably that it's fundamentally changed the way your body responds to food, at least in the short term, which is why they're probably going to switch it to a longer time period.
Do you see anything wrong with this? Do you see anything controversial? Do you see anything that could potentially raise red flags for the FDA or Anesthesia Society? I mean, what do you see?
I don't think so. I mean, I think this is a weight loss drug like any other weight loss drug. Probably the most popular way before the GLP-1 agonists to lose weight was the gastric sleeve. And so that's essentially the same idea, right? A gastric sleeve just basically reduces the size of your stomach so that you can't eat as much and you thereby lose weight. It's the same idea. You're just doing it pharmacologically instead of mechanically. So, I don't see this being a big controversial issue in terms of the medications themselves, but I think there's going to be a lot of evolution of how long are you off these medications. And also probably NPO. So how long do you not eat? My guess, I don't have any insider knowledge here. My guess is they switch it to 2 weeks off of the injectables and 2 days off the orals. Plus they change it to 18 hours or more not eating anything.
Okay.
Would be my guess. I don't know for sure. But, and I guess controversy-wise, I guess some people would call this sort of a shortcut to losing weight, but so's anything else, right? And they've had weight loss medications. You've got whatever it's called, Contrave, I think was the name of the medication, which was a mix of, I think that was like naloxone and Wellbutrin. You've had phentermine, which is Adipex, which people have probably heard of. So all those had not great ability to help you lose weight. Moderate, not like this, and then they had a bunch of side effects. So this one's probably got the least side effects. The only thing I think that could change is if there's some large-scale study and there's some huge long-term side effect from these medications. It may change at that point, but as of now, I don't see it changing.
Muscle mass, we're going to talk about that here in a few weeks with Rodney Razor.
Our trainer.
And, we're going to talk about that in the next season. So you want to make sure to ask those questions. If you have the questions online, make sure to drop them below. You can always answer the questions on social media too, which is what you do. But the biggest thing I think that people are experiencing is muscle mass loss.
Yeah, so it's interesting. They call it Ozempic face, or so people tend to lose not only body fat, but muscle mass if you're not exercising, getting enough calories, protein, that sort of stuff. So. Yeah, for somebody who's, super morbidly obese, who's got a BMI of 70, right? You're not going to have quite the same sort of issues as somebody who may be a BMI of 32 and trying to lose like 40 pounds.
But just a quick question on that, and then we can kind of, I think we're going to end the episode without any questions today, because I think we're going to get a lot of questions here over the next couple of weeks on social, and I want an opportunity for you to answer those. But my last question is, with that, you're losing muscle mass. Does that pose a risk for surgery, like in terms of like, I'm BMI of 30, but is it going to not help me wake up from surgery? Does it change the...
Yeah, I mean, I guess it could, in theory, change your volume of distribution, but we're not finding a huge difference. Okay. Patients typically do have more nausea, even if they're appropriately NPO and they have appropriately stopped their medication. They tend to have more nausea after surgery, just probably because even their secretions that are going in their stomach probably aren't going through. But no, it doesn't really fundamentally change the way that we're doing anesthesia. Muscle mass and the ability to heal are somewhat related.
Okay.
So you may heal a little bit more slowly, particularly if you're not getting your full complement of nutritional needs. I don't think these are going to be gigantic issues, but it is interesting, at least in terms of the way that the body changes, right? Because you're going to lose fat, but you're going to lose a lot of muscle as well if you're not working out, getting protein, trying to keep the muscle up while you're losing the fat. And you can look sort of gaunt and wasted away if you don't do it the right way. So
I'm going to put you on the spot. If you were my doctor and I said, hey, I'm going to take Ozempic and whatever, would you be okay with that?
Yeah, I mean, I don't think that the side effects are that extreme. I mean, if you told me, hey, I'm planning to have surgery in 6 weeks, should I start Ozempic? I'd say no, wait. But aside from that, yeah, I mean, I'm not fundamentally opposed, and I'm not a primary care doc, and I'm not a weight loss doc. So, and this is not medical advice, but
which you don't give,
which I don't give, at least unless you're my patient.
Right.
But they work well. I don't see any reason why people can't take them. And now with the reduction in cardiovascular risk that they're shown, I'd be surprised if more people aren't put on them just for that. Because we don't really have, aside from diet and exercise and reduction of cholesterol, we don't have a great way to prevent cardiovascular disease. So if these are doing it, I think a lot of people will be on them. And I'm not opposed to that.
Well, I'm willing to go on a limb and say that there's going to be more research done here on these over the next year, 2 years, 3 years, whatever it may be. This is going under Anesthesia Answered with Dr. Brian Schmutzler. This is our last episode of this
season one. Yep.
Season one. It's been a really good season. We've got a couple episodes coming up with Dr. Adam Cian, friend of yours, who resides in this town as well, and you guys work together.
We do.
And so we'll have a special episode from him kind of in the break over the next month. And then July, we are going to come back full force with season 2. And the aforementioned Rodney Razor is going to kick us off with part 2, essentially, of this Ozempic conversation, revolving around how to go about, if you're going to do this weight loss drug, what's the physical side of it, and how can we stay healthy in terms of that? So, Brian, thanks so much.
Yeah, thanks.
It's a good conversation. I'm sure we're going to get a lot of questions.
I imagine it's a hot topic right now. So,
all right, follow Dr. Brian Schmutzler on all the social medias, and of course his website as well. And you can drop a comment or a question on all of those platforms. Thanks so much, Brian.
Thanks.
We'll see you in the next one.